computer. Okay, sorry, everybody that put their name in the chat, you have to redo it because now I'm recording to take attendance. So everybody, new and old, early, everybody put their name in the chat, please. Starting now. I figured that out a couple of weeks ago. When I was going back and doing attendance, there were only a few names in there, and I realized that I hadn't started recording yet. So now that we're recording, that's how I can get everybody in the chat. Excuse me. Desiree. Where's Desiree? Oh. We may have some extra students here because the RN classes on Thursday and Friday, there's no classes. So the other instructors offered my class for a live lecture today. So Desiree, hi.
Hi.
How are you?
I'm fine. How about you?
Good. Thanks for coming. What class are you usually in?
Dr. Lundy.
Okay. Well, welcome.
Thank you.
Hi, Annabelle. Excuse me. Desiree, Annabelle, put your names in the chat, please. I would appreciate it.
Okay.
Okay, I'm going to get started since we got a lot to cover today. So, Desiree, if you put your camera on, that'd be fantastic.
Okay.
Appreciate it. Wendy, I can't see you. I can just see your ceiling. Then we have Sean that's coming in. Hey, Sean.
Hi, how are you?
Hey, great. How are you?
I'm all right.
You coming in from Dr. Lundy's class?
No, Kershaw.
Oh, well, I think she's teaching today.
Is she?
Yeah.
Oh,
She should be.
I don't know. She just sent out the thing and I just went with it.
Okay. Well, you can stay here. It's fine.
All right. Thank you.
Yeah, sure. All right, everybody that's just come in the last few minutes, make sure you put your name and your professor in the chat. Not professor, but, well, for those of you that are not my students, put your professor in there so I can send it along. Okay, let's get started. Welcome to week 8 and happy day before Thanksgiving. Can't believe it. Everybody ready for Thanksgiving? Everybody get their birds ready to go? I actually did it the other way. I was home in Colorado for a couple of weeks. So I had my kids over for an early Thanksgiving a couple of weeks ago as to eliminate any guilt that I was feeling about leaving town again for Thanksgiving. So I've already done my bird, but apparently I'm doing another bird for tomorrow. So anyway, well, I hope everybody, if I forget, has a really happy Thanksgiving and can try and carve out some time for family and relaxing tomorrow before you get back to the grind. I'm going to try and do the same. So we are in week 8. We are almost done. I believe this would be our last lecture for content. Okay, so we have 8 chapters to cover today. This is our last week because next week is week 9, which is your exam. And in week 10, we use that entire week to do Hesi reviews. So our week 10 class will be an entire Hesi review. And I'll be sending you out the schedule of all the other classes that are offered in week 10. I think there's 12 of them. And feel free to go to as many classes as you want during week 10, because all different instructors, we're all doing the same thing. We're all doing Hesi reviews. All right. So I think we lightened up the guidelines last term. I'll have to double check, but I believe we said you don't even have to come to this class as long as you go to one class during week 10 for a Hesi review, but I'll clarify that. Okay. You should all have your Hesi review booklet, I call it, since it's 60 pages or close to. However, I know that seems overwhelming, but remember a couple of things. One is your Hesi review study guide, even though it's 60 pages, is a compilation of the whole term. All right, so that's why it's long.
Hello.
Hello?
What are you doing?
Hello? So remember, that's a compilation of all the content from all term. Please don't wait till week 10 to open it up, because it's going to be extremely overwhelming. Okay, you should be kind of going through it piece by piece. I would highlight the sections or cross the sections that we've already covered. I mean, after today, all the sections in there should be covered. And remember the Hesi study guide. For Hesi, you should be studying your 3 study guides from the exams plus your Hesi review. Okay. And also remember that the Hesi study guide may not look exactly like your 3 study guides from the exams. We have actually reviewed prior Hesis from all of your remediation that you did. And we were able to at least get topics, concepts that are covered. We don't know the questions on the Hesi. We do make up our own exams for 1, 2, and 3, but we don't do the Hesi. The Hesi is like NCLEX, where they pull from a bank of 1,000 questions. Okay, but we are able to see what topics are covered. Dean Brown is going to be joining us. Hello, Dean Brown. Welcome.
Thank you.
So the Hesi, going back to the Hesi, the topics and the concepts are what's in your study guide. Okay, that's from reviewing previous Hesis. So at least we know the topics that are covered, but we don't know the questions. Okay, so all of that should be covered in your Hesi study guide. So when you get prepared to come to week 10 classes, whether it's coming to this class or another professor's class, or if you go to several, remember that to review your study guides from your 3 exams and put that together with your Hesi review. And that should be a pretty comprehensive review. Dr. Lundy sent out this morning, I haven't had a chance to share it yet, but one of our teammates, Professor Price, just did a pretty long Kahoots for Hesi review. So I will get that sent out this afternoon after class. And so add that to your resources for studying for Hesi as well. Okay. But first and foremost, we have exam 3 next week. We started reviews this morning. I had my review this morning. Didn't have great attendance. I probably had, I don't know, Savannah, who was there? Savannah was there and Sydney was there. So I think we had about 6 or 7 people. What do you think, guys? 6 or 7 people? What did you think of the review? Sydney, Savannah?
It helped. I mean, we went through, and because my biggest problem is priority questions. We went through and was looking for keywords and what to look for and how to assess that question or what could be a possibility.
Mm-hmm.
Understanding how a question might be asked kind of gives you a better idea how to answer it too. So I think that helps.
And one of the things, let's see if I still have it in here. I do. So I'm going to share my screen real quick because one of the documents I covered this morning at the beginning of the review was preparing to take an exam. And this is a tool that I use with my students when I do tutoring before an exam, or I do an exam review after the exam. Okay, so I just want to share that with you real quickly. But I also want you to know that I'm still available to some of you that got below a 78 on exam 1. I haven't even heard from yet. Okay, and same with exam 2. I mean, I have a lot of tutoring scheduled. I think I met with 9 students yesterday. So I'm still available to meet to do exam 1, exam 2, do them both together at this point. But you guys have got to reach out to me to review them. Okay, especially if you got below a 78. It is critical to go through that exam and figure out what you got wrong. Because what I'm seeing is a lot of students are missing those key words and phrases in exams. So, priority questions, what do you look for in a priority question? The most, the least, the greatest. The other thing that's being missed is the positive versus negative questions. Okay, so I just want to show you a tool that I use when I review. And I'll go through it briefly, but if you guys watch my review that I just sent out from this morning, it goes through this document in detail. All right, so let me show you this real quick and then we'll get to our content. First, I need to share my screen. That would help. Okay, so this is the document I use when I go review with students. We talk about your exam performance, lack of knowledge, test anxiety, testing skills. Okay, and I personally think that reviewing with me is really helpful because we really dissect what happened in the exam. So it's not too late to reach out to me. Okay, we can meet. If you want to meet before the exam, if you've done your due diligence before exam 3 and you've gone to a review or a couple of reviews, you've gone through your study guide, you've researched your study guide. If you don't understand things on it, you've gone back to the chapters to do your own due diligence and try and understand that concept more. If you still have areas of the study guide that you're not understanding, it's okay. Just reach out to me. We'll do a study session or a tutoring session prior to the exam. I mean, you guys don't take the exam until Wednesday. You'll be taking the exam a week from today. So reach out to me over the weekend and we'll schedule something for Monday or Tuesday. Okay. Anyway, this is the part that I go over in detail in my review from this morning. It's suggestions to improve your exam performance. And this goes with Hesi too. Okay. So Sydney and Savannah, we went over this morning. Was that helpful?
Yes.
Yeah, it just gives your suggestions for exam performance with regards to lack of knowledge. Here's some tips. Exam taking skills. Here's some tips. And exam anxiety. Okay, so that is in detail in my review session. Okay. Okay, any questions? Any questions about preparing for exam 3 and Hesi? And by the way, you guys did a fabulous job on your group projects. Fabulous, fabulous job. So, the great thing to read was the peer reviews. And I was going to send out a kind of a all hands message, but I thought I'd tell you in person, the peer reviews on each other were absolutely fantastic. I know you guys like to work with students, with teammates from your own campus. It's easier, but I kind of like to break it up so you get to meet students from other campuses. But I didn't have one issue with any group in this class. You guys all worked as a cohesive team. You submitted really, really great group projects, followed the APA guidelines, and the peer reviews of each other were just fantastic. So it sounds like everybody had a really great experience. Anybody want to add to that? Okay. Okay, let's get into content. So instead of going through the book, 8 chapters, that's a lot. There's a PowerPoint that we go through. There's a pretty large PowerPoint, but it covers all the material. So I'm going to use a PowerPoint today. Okay. And so remember though, that you're responsible for the information in the book, but the PowerPoint does highlight the important parts of each chapter to understand the concepts. Okay. Don't forget in the books though, in these chapters, what are the things that you really need to review in these chapters? What are the two big things that you review every chapter? In each chapter.
The Healthy People 2030.
Yep. What else? LOP. Come on, you guys, you read it in every chapter. I just gave you the acronym.
The learning outcomes.
Nope. Jean. Come on. Come on. You were with me last term. Come on. The levels of prevention. Right?
Yeah, I was on mute. I was saying.
That's okay. We need to you guys need to understand the levels of prevention from each chapter. Well, because they're presented differently in each chapter. So if we're doing, let's see, today we're doing ethics. So in the ethics chapter, the levels of prevention, primary, secondary, tertiary, relate to ethics. Okay, if we're doing case management or disaster management, the levels of prevention box in each chapter outlines that specific topic. Okay, all the exams, including exam 3, are full of level of prevention questions. So you do have to have an understanding of that. And you guys are doing well. So I know you do, but you have to review those levels of prevention. Okay, so let's go to the PowerPoint. Let's see. So the first chapter in the book is chapter 6 for this week. Okay, and it is ethics. Oh, did I not share my screen? Hang on, let me go back. Where are you guys? There you are. All right, can you guys see my screen? Okay, so I can only see a few of you now. So please, everybody, keep your cameras on and I need you to participate as well. Okay, so ethics. Let's just first talk about ethics. Why is ethics important in nursing? We practice ethics every day. Every day we go to work.
Because right over, you know, the difference between.
Go ahead, Brittany.
I read that you have to know the difference between right and wrong.
Okay.
And how to advocate for your patient. It's principle, pretty much.
Okay. What else? What are some other reasons ethics are important? Ethics are critical in our practice. Pardon me?
Trust. Your patients won't trust you if you're not, if you're behaving unethically. Safety.
Mm-hmm. Trust and safety. Yeah.
Helps with harm
Excellent.
prevention.
Helps with what?
Prevention.
In what way? Harm prevention. Yes. Okay. What else? I mean, we essentially practice ethics in our daily lives everywhere. It's just not at work. It's not at clinicals. It's not in class. It's in our daily lives, right? Ethics, doing good, doing no harm. So here are our 4 ethical principles that we need to understand. Okay. Respect for autonomy, non-malfeasance, beneficence, and distributive justice. Okay, I'll start with the two pretty common ones that we should be familiar with, which is the malfeasance, which is do no harm. Okay, so non-malfeasance means that we are required that we do our best to do no harm. Okay, we know it's impossible to avoid harm entirely, right? But because we are practicing within a scope of practice, our standards of care, we are always trying to act in a way that we do no harm. Okay, the other common principle is beneficence. Okay, doing good. Okay, we have an obligation based on our standards of care and our scope of practice to do good. Okay, we do not place undue burden on the healthcare providers. Okay, we do good. Distributive justice, right? That means that we have to be fair in our distribution of resources. Okay, so we have to distribute equally the resources we have. And a lot of times, if you're going to be working in community health, public health, we as nurses are responsible for those decisions. You know, when I was in the schools, I had a lot of responsibility of deciding or trying to work with a team to come up with, oh, how should I say it? Spreading out the resources we had in the school building for healthcare of kids. You know, who are kids that needed, you know, G-tube feedings, that needed trach suctioning versus the kids who were coming in for their daily meds. Okay, but this principle recognizes that everybody has an equal right to resources and services available. Then the last one is autonomy, respect for autonomy. Okay, if the client is capable, they should be the one that makes their own decisions, makes their own plans of care, makes their own decisions based on what they see as their lifelong goals and plans. So autonomy, exactly what it says. We want the client to be autonomous in making their own decisions, if capable. We don't want to be making their decisions for them. Okay, so ethical principles, these are really important to understanding how nurses, how our profession looks at issues or ethical issues. So I have a quick question. So I'm sure a lot of you work, right? What have you come across? I'm actually going to stop sharing my screen because I want to see faces. I know everybody has dealt with an ethical issue. I dealt with many ethical issues in the schools. Tell me, give me some examples of some ethical issues that you have been involved with in your workplace or in your clinicals. Nobody has had any ethical issues come up in their workplace.
I wouldn't say it's an ethical issue what I experience at my job. I'm the only, not I want to say one of two that only speak Spanish. So I would always have to go ahead and go to the front and translate for anybody because there's a lot of people, not only in Miami per se, but that don't speak English. So I would always have to translate because unfortunately some are either embarrassed or they don't want to put the effort to learn to speak English. So I would always have to go ahead and translate.
Oh, that's an excellent example. Juanita, sorry, are you driving? Juanita? Okay, give me some other examples. Good example, thank you. Has anybody had any ethical issues with regards to plan of care in working with different cultures? Different cultures have different values, different beliefs, different ways they want to do things. That's a big issue.
There's like a lot with like blood products and like needing blood and them not wanting it.
Mm-hmm.
It's off of religion.
Right? Who else? What about end of life care? Does anybody work with hospice patients and end of life decisions?
We actually had a big one in ICU back during COVID. She had gotten sick and she had made her, it was a relative, but it was also a neighbor. She had made her power of attorney and the person that was to speak for her because she didn't have anybody else around. Well, when this patient was put in ICU, she wanted to be a DNR, DNI. She didn't want paid tubes or anything. And when this patient had to be, she agreed to be intubated because she was struggling to breathe and she was having panic attacks. So she told me she wanted to be intubated, but she didn't want trachs, nothing like that. Well, we got another doctor in because we were doing a lot of doctors alone at that time. And the neighbor, which was also a family member, came in and said, no, you can't do this, you can't do that. Well, when they found out she was the neighbor and she didn't have any, I don't even know how you have familial proof that it was actually your cousin or whatever, I don't know. But the doctor went ahead and trached this lady and pegged her and sedated her, while the family member was like, no, because she didn't, even though she was the next of kin. And when the patient woke up, she was furious. She had a trach and a peg, and she was a young woman though. I mean, she was just miserable about it. And the doctor got a patient advocate assigned to this patient because he would not believe that this lady, who was her power of attorney, was a family member. So, I mean, I feel like that's a big ethical issue.
That is a huge ethical issue, and that is not that uncommon. I just had a couple of weeks ago, I have a dear friend who passed away, but what happened was she went in to get her pacemaker battery changed, and she aspirated. And so she was put on a vent, and she communicated after being on a vent for probably a week that she just wanted to be a DNR. And her family, her husband Casey, didn't agree with it, and nor did her kids. And one of her kids is actually a nurse. They did not agree with it. And so they wouldn't go along with what she had communicated. So the ethics committee at the hospital had to get involved and make a decision, right? And they sided with Sharon. They felt like, even though she aspirated and was on a ventilator, she was mentally sound to make her own decision, and she was taken off everything. So it was a really hard situation, but again, another ethical dilemma. Right.
No, it's surgery services that our patients, even if you're a DNR and you have a signed DNR on file at the hospital, once you go into the surgical suite and you're put under, you're automatically made back into a resuscitate. They have to resuscitate you during surgery, which I feel like is ethical issue as well.
Yeah. So we as nurses are going to be dealing with ethical issues like some of the examples we just shared all the time. Okay, ethics really comes into play, especially in community nursing with cultures, right? Can you see how that happens? Because we are caring for many, many different cultures. Many different cultures have many different beliefs about the food they eat, the privacy of their information, they just have a lot of different requirements or different beliefs and values, and we have to be able to do our best to take those values and beliefs and practices into account when we're caring for these patients. So as much as you may not think that ethics, I know you know ethics plays a big role, but we are continuously faced with ethical dilemmas, ethical issues in our practice on a daily basis. Would you agree with that? Okay, let's keep going here. Thanks for that discussion. I'm going to be skipping through here. We're not going to be going through every one of the slides. Okay. Okay, so so now we want to talk about ethical theories. Okay, so ethical theories, these theories help us guide our decision making. Okay, and the first one, the first one is utilitarianism. Okay, what is utilitarianism? Think of the word utilitarian. Okay, the greatest good for the greatest number of people. Okay, the greatest good for the greatest number of people. Okay, the other theory is consequentialism. Okay, and that is based on outcomes or consequences. Okay, the greatest amount of good or the least amount of harm in a particular situation. So it's about consequences. Okay, so those we need to have understanding of both of those. So we have ethical principles, whoops, and we have ethical theories. Okay, applying the utilitarian ethics decision process. How do we do that? Okay, morality. We are determining what moral rules are important. Okay, what populations, what people are most affected by moral rules? Okay, we select the actions based on the rules that produce the greatest amount of good and the least amount of harm. There's also an ethical theory, third one, deontology. Okay, and that's where we talk about the moral rules, adhering to the moral rules versus the consequences. These kind of all blend in with each other, but they all have their individual outcomes. Okay, so what about ethics in public health? Well, I know we have ethics in the hospital, we have ethics in clinicals, clinics, healthcare facilities, but we also have principles of ethics in public health or community health. Here's an example. Reduce the potential influence of a genetic risk by teaching clients how to live healthier lives or address the individual health effects of environmental risks within the communities. Examples: drinking water, lead levels, air pollutants, radiation exposure. What level of intervention would that be? The orange box. Would it be primary, secondary, tertiary?
Primary.
Why? What?
Primary. This is teaching before an event.
Trying to prevent something before it happens.
Right.
I mean, that's actually ethical. I mean, primary prevention in this case is actual teaching ethics, right? We are obligated as public health nurses to provide primary prevention as much as we can, And in this case, teaching clients how to live healthier, right? Or warning them of potential environmental risks. And the environmental risks being the drinking water, the lead levels. So here's a question to ponder. Let's talk about this for a minute. This gray box. Should people be held accountable for making unhealthy life choices? To whom should you give the information about genetic predisposition to an environmental health problem? Should society's resources be used for people who knowingly engage in risky behavior, given their genetic makeup? Those are 3 ethical questions. Let's talk about that. The first part, should people be held accountable for making unhealthy life choices? What do you think?
But what is held accountable? I guess that's the question.
What do you think it is? Let me start with Eugene. You have an obese person that you're trying to work with, and they don't seem to know that, or they don't seem to want to believe or practice that a healthy diet and exercise may help reduce their weight, but also maybe increase better their lifestyle. Should those people be held to the same accountability as others who are following or adhering to or practicing to try and get better?
In my opinion, yes, because it kind of like you can look at certain people and say, okay, well, this person has done this and this person has lost the weight, and you can do it. There's things backing up saying like, okay, it can be done. I think you just have to push a little bit harder with people. Some people don't have the drive to do that. So you might have to talk to them just a little more than others. But I do think they should be held accountable.
I think that there's a lot of them are held accountable with these like gastric bypasses and stuff, because they make them go on these diets and do these, exercises and lose so much weight. And then if they give them all the resources, the therapies, and then they continually miss their goals, they refuse to do the surgery on them. So I think in that aspect, I mean, they are being held accountable. You don't do your due diligence, you're not going to get the surgery. We're not going to give you our services.
And is that okay to refuse services?
I feel like if you're given every opportunity to receive those services and you're not doing what you need to receive them, then that's on you.
Can I interject something, Kathy?
Yes.
Okay. Talking about obesity, talking about overweight. You have a patient that has presented to a clinic. They are 40s, 50s, truncal obesity. Limbs are more skeletal. We all know that there are different places where fat occurs based upon different reasons. When you are looking at this person, what tends to come into your mind?
Are you asking like if it's negative or positive things that
I'm
comes?
just asking what comes into your mind when you're looking at this person.
How did you get there?
Okay.
What are you doing, to stop it, or do you want to stop?
Okay.
I look at family genetics and like hormones, labs, because a lot of that kind of stuff also goes into weight gain.
Okay.
think there's a lot of psychological things that go into severe obesity that they need to, a lot of times they need to get those things under control. If it's somebody that's there for a problem with severe obesity and they're looking at something like gastric bypass surgeries and sleeps and those things.
Okay, so now go back and think about in your past courses. Somebody with truncal obesity with the limbs being normal sized. So Jean, you mentioned, what are you doing to take care of the problem? Okay, what would that question make that person feel?
I would assume that person would feel embarrassed, angry.
Okay.
How do you know I'm not doing anything to take care of the problem?
Good. Okay. And Kayla, you mentioned something about looking at labs.
Yes.
Okay. So, and where I'm going with this is there is a significant number of people that appear obese, and it has nothing to do with their habits.
For sure. Yeah.
Okay. And truncal obesity, when you see somebody with truncal obesity, automatically I'm thinking endocrine disorder.
Yeah.
There's not a thing they can do. And it generally hits them in their mid-50s, 40s, and it's generally women. And so when we look at ethics and we look at withholding treatment because they're not following a regimen, they're not following a prescribed plan of action, we have to be sure we check our own thoughts, our own prejudices.
Oh, well, I do have something to add on that note. Right there, just for exam purposes, we were just going over the GI system and we were talking about these surgeries for people who had obesity. And one of the things that we talked about withholding treatment for was failure to be able to follow the plans for surgery. Was we didn't want to do the surgery because they would not be able to follow the plan after surgery, which is very, very strict. And so with that being said, is that along the same lines of all of that, or is that just a totally separate thing? Because now I'm a little confused.
Well, welcome to the world of medicine. It's very confusing. There is no clear answers. It's all black and white. And there's no black and white, it's all shades of gray. And so, and that's why you have to really look at every instance. You know, we can give you basic, but you have to really look at every instance. And, you know, any of us that have been practicing for a while, we know there are people out there that are what we call non-compliant. And that in and itself is very derogatory. Because what we don't look at is, are they not following what we've prescribed for them because they don't understand, because their level of cognition is lower? Are they not following because they can't afford, because their income is too low? Are they not following because, you know, maybe they don't have the ability and the mobility to get to the resources that we need them to get to in order to carry out these plans? So without looking at things like that, we label them as non-compliant. And are they really non-compliant, or did we not go deep enough? And yes, there are some things that we really have to look at. When we look at surgical interventions, if they can follow or not. And, you know, some of the big things I look at is liver transplants. for alcoholics and drug abusers who have spent their life on, with abusing alcohol and abusing drugs. And, they basically tell you that they're not going to give them up. Do we want to use an organ because they could pay for it, because they've got the income, because they're well known, because they're a performer, versus the street person who's on the street because life kicked them out there on the street and they're doing their darndest, and they have a genetic disorder or a autoimmune disorder that has destroyed their liver, but they can't afford it. So which one are we going to give the transplant to?
These are ethical dilemmas that we will, I'm going to step one back from Darlene too, is as we're doing our assessments with our clients in our community, we also have to assess barriers, right? We need to have an understanding of, if we're talking about the obese patient, what barriers are they facing that are preventing them from moving forward towards a healthy lifestyle? Is it lack of income? Is it lack of motivation? Is it lack of, is it predisposing factors? Is it low health literacy? And that's all part of your ethical decision-making as well, of how we look at this patient in totality.
And when you look at obesity, there are some treatments that we do and give our patients and put our patients on that causes obesity.
Mm-hmm.
Steroids will cause truncal obesity. That's your Cushing's patient. Antidepressants have a high propensity for causing weight gain. Do we have them give up their antidepressants to be on this healthy diet and and suffer mentally and psychologically? Or do we give them the medications they need to straighten out their psyche and their imbalances in their brain, knowing they're going to be putting on weight, that could be a risk factor for causing diabetes, heart disease, all those other things? It's not black and white. So we have to make decisions, and we have to check our own prejudices. And I will tell you, I've been heavy set my whole life. So I understand, I hear, I've heard it all.
Anybody want to add to the discussion? It certainly, there's just so much to consider when you're making decisions for the patient or making decisions of a plan of care.
Brittany, give me your thoughts.
Pretty much, like you've mentioned before, you can't judge a person. You can't just walk into a room and see a person that is obese and think, why aren't you eating properly? Why aren't you taking care of yourself? Because you don't know what factors led to their obesity. It could be medication, like you've mentioned. It could be a thyroid issue that they have and they're unaware about. It could be many factors. It could be that they've been abused and they use food as comfort. So it's many different things that can lead to obesity. So judging someone based on how they look, it's not ethically correct.
Okay.
I mean, it also goes the same way as for someone being skinny, because I've heard it my entire life. Someone being super skinny, you automatically place them as not eating enough or anorexic or anything, and not knowing their actual, because I mean, I have health problems, and my entire life people, they make skinny jokes and they think that that's fine. It bothers us the same way as you calling someone fat. I mean, It literally drives me up the wall. And what they don't know is I do have health problems that I have struggled with my entire life, and it doesn't make it any better me being skinny or if I was fat. I mean, you don't walk in and just judge somebody. So it goes both ways.
Yeah, I was just gonna say the same exact thing. I had a friend who was very, very thin, and people would make comments about her, and it was either she was on drugs or she doesn't eat or whatever it was, and it really, really got to her. And so for a long time, she ended up she would bring bags and bags of really terrible food into work, and now she's put on so much weight that now people say the opposite of her. So and she did have a lot of health problems, but it's a
I mean,
shame.
I get that. I've probably I'm still skinny, but I weighed 107 pounds 6 years ago when I had my kid, and now I'm like 145. And people's like, oh, you put on weight. You actually must be eating now. And it's not that. I've finally gotten these health conditions under control. I'm altering my diet for what I should be. And I'm not really taking care of myself, but I'm medically looking at it at a different standpoint. So it still doesn't hurt. I mean, it hurts me now that they say that now. At some point, I mean, you just keep your thoughts to yourself and go in there and assess the situation by what they're medically, whether it's labs or whatever, instead of putting your opinion. Your opinion doesn't matter. It's not going to change their outcome or their treatment.
Right. More or less just hurt them.
And you have to look at the patient in total, the total look of the patient, psychological needs, physical needs, right? Emotional needs. There may be there's a lot more going on to that patient than meets the eye. And that's part of our role as a nurse that's where our assessment comes in. And that's why when we talk about culturally competent care or culturally incompetent care, are you taking the totality of the patient, the client, in the community into account? And checking our own values and beliefs, like a couple of weeks ago when we talked about the homeless population and the drug addicted population and the chronic mental health population. Are we able to check our own values and beliefs and to be able to care for these patients, clients? Because in the community, remember, you don't have all the resources that you would have in a hospital, right? You are it. You're walking into that home, and you may be walking into the home by yourself with an extremely obese patient, extremely skinny patient, patient with COPD, a kid with asthma. You're walking into a variety of situations. Are you able to step back and evaluate the whole picture, right? Without making assumptions. Yeah. Good discussion, really good discussion. Does that help? You take a look at things. That's our nursing process, right? Being able to do an assessment, come up with some desired goals and objectives, come up with a plan for this obese patient, come up with a plan for the COPD patient, implement that plan. One of your first case study in the ethics chapter 6, is about kind of what we just talked about, a patient with chronic illnesses that the nurse keeps visiting, and he's making no progress, but he's not making any effort to make any progress. And the case study asks the nurse to step back and evaluate the whole picture. Is there a reason he's not capable of helping himself? What barriers are there for him? Okay. So ethics is, it's always going to be part of our decision-making process. Okay, let me skip down here because I want to go to There's a couple of other kinds of ethics, ethical areas that I want you to be familiar with. One is, where is it? Feminist ethics. Feminist, virtue, feminist, and care ethic theories. Okay, so I want you to have an understanding of each of those. Okay, feminist, so feminist ethics, okay, in particular, they advocate for economic, social, and political equity. Okay, they pay attention to the power relations that constitute a community. Okay, so that's what the feminist ethics, those are their biggest concerns. Okay. Okay, let's go into cultural influences. That's our next chapter, right? We are, you guys can see my screen, right? We are caring for numerous culturally diverse groups in our practice, wherever we work, whether it's in the hospital or in the community. Okay, there are certain definitions of immigrant categories I want you to understand. Okay, we have 4 categories of foreign-born people. And this is right in your chapter of chapter 7. We have legal immigrants. Okay, these are lawful permanent residents. We have non-citizens. Okay, non-citizens are lawfully in the US and can enroll in Medicare and CHIP programs. Okay, so those are the lawful citizens. Second category are refugees. Okay, what's a refugee? Person who received refugee status. They're here legally and they can receive the benefits. These are typically people that have come from war-torn countries or their safety has been in jeopardy in their own land. Okay, the third is non-immigrants. Okay, these are people who are admitted for a limited time and for a specific purpose. So maybe students, maybe migrant workers, diplomats, whatever. Okay, and then the fourth is unauthorized. So those are undocumented or illegal aliens. So please understand there are 4 categories of immigrants and a brief description of what each one of them are. So that if you were asked a question and you were presented a scenario, you could identify which of these 4 categories they were. Okay. What are some things that we need to consider when we're dealing with immigrants? Okay, or barriers. Language, certainly. Culture, language, different social, religious, cultural backgrounds that we need to take into account for our plans of care. Maybe their health literacy versus health illiteracy. What kind of knowledge do they have about their diseases? Sorry, I need to get the sun. What knowledge do they have about the healthcare system, how to access resources, about their diseases? I mean, typically this population is going to show up when they're more in their advanced stage of an illness, right? They're just not aware of primary care at this point. Right? And here's an ethical question. What do you do about the immigrants that rely on traditional healing or folk health practices? You know, and they're in your hospital and they want to have their traditional values as part of their healthcare plan. And you're not aware of, you're not uneducated, but you have a lack of awareness. What is the best way? Here's a question for you. If you're working with clients of different cultural backgrounds and you don't know a lot about their culture, and this happened to me in the schools all the time, What do you do? How do you become knowledgeable about their culture?
Is it okay to ask about them?
You ask them. You ask them. You have them be participatory in their plan of care. Right? I mean, most I'm sure we can accommodate. There's probably certain things that maybe can't be accommodated, and that's discussed with the patient, but asking them, having them tell you about their culture and their values and their beliefs, that only increases the trust factor, right? And their willingness to communicate with you. We all know what a culture is, right? Everybody's has a different culture, set of beliefs, values, and assumptions. Okay. We know what race is. Cultural diversity, right? Simple. It's the degree of variation represented among different populations. Here's some examples of primary, secondary, and tertiary with related to culture. Okay, so primary, provide healthy teaching about a balanced diet. Great. Right? Secondary is about screening, teaching them to monitor their blood pressure, teaching about diet, keeping in mind the client's cultural preferences, talking about health beliefs and cultural implications, alternative therapies, making sure alternative therapies are compatible. So I was just talking about compatible with medications that may be prescribed or compatible with their health plan of care. And then tertiary. Let's assume they have a high blood pressure and they can't control their blood pressure with diet. Maybe we're referring them on to a physician for medication. Does everybody understand why those are primary, secondary, and tertiary? Lots of different cultures have different beliefs about time perception. Some are past oriented, present oriented, future oriented. Healthy People 2030 objectives related to what are their objectives with regards to culture? Okay, since this is in the PowerPoint, I would suggest that you go back and review in chapter 7, the Healthy People 2030 box. Okay, here's the 3 right here, the 3 selected objectives. Increase the proportion of people with a primary care doc. Increase the proportion of adults whose healthcare provider checked their understanding. Really important. Do they understand what you're saying? And then increase the number of adults with limited English who say that their providers explain things to them. How do we develop cultural competence? Right? We know that the more culturally competent we are as nurses, the more effective we can be in providing care to clients of other cultures. And we know that cultural competence is a core competency of nurses. It says public health nurses, but nurses in general. And cultural competence is a lifelong learning process. I'm still learning about different cultures of my students. Okay, and I'm 40 years into nursing. Okay, questions about cultural competence. What happens if you... I had a student probably 3 or 4 terms ago. She worked in a prison. Okay. She had to take care of the clients in the prison. One of the clients was in there for murder. And that client murdered one of her relatives. So what kinds of dilemmas do you think that created? If you were that nurse working in the prison, what would you be thinking? I'm gonna just look at everybody's faces. What would you do in that
I wouldn't
situation?
want to take care of them. I mean, that's like, ugh, I couldn't even imagine.
Mhm. What
Yeah,
else?
that's pretty hard. Like, you know, we get people that come to the hospital now and they done things where you'd be like, you know, oh man, I really like this guy's the way he is and his attitude and what he done in his past. You kind of question it and go, you know, I don't want to take care of him. I don't even want to go in the room, but a family member, that's hitting really close to home. So that's hard.
Mhm.
Would that be considered like a conflict of interest in a way? Like when they come into the ER, if we have like a family member or something like that, we're not allowed to treat them, be in the room or anything like that. So
Good question.
would you be able to have, you know, one of the other nurses take care of them or something?
That was my next question. So if you are just incapable of being able to take care of that patient, what do you have to do? You can't just blow the patient off. What do you have to do?
I would assume you go to the charge nurse and ask for a different patient.
That's partly right. You have to make sure that this client is cared for. So in this case, there were two other prison nurses that also worked there, and she removed herself from caring for that client. But she made sure that if the client needed assistance, somebody else was available to take care of that client. But she did remove herself from the situation. But that's a hard one. Okay. Okay, case management. What is a case manager? What does a case manager do? You guys probably work with case managers all the time. What do they do?
Well, the ways
Referrals
that-
to
Go ahead.
specialties.
Okay. Okay, so they do referrals. Does anybody work with discharge case managers? When a patient is getting ready to be discharged? So case managers are coordinators of care. Okay, so you may have discharge case managers, you may have cardiac case managers that take care of or coordinate care for post triple bypass patients. You may have stroke case managers, you may have all different kinds of case managers. Okay, they are the coordinators of care. So for example, they may be coordinating care between financing, delivering services, home health equipment. Let's transition from the client who's in the hospital to a client's going home. So we have a discharge case manager. What kind of care, what kind of resources might they need to coordinate? What if the patient's on oxygen leaving the hospital? What needs to happen?
Home health.
Okay, so they need to coordinate with home health. Sure. They might need to coordinate with the oxygen company to make sure there's oxygen at the doorstep when they get home. What if it's a stroke patient that needs PT? All these services don't just come together and everybody shows up. Somebody has to be coordinating that. And that is typically the job of the case manager. Okay. And so case managers over the last 10 years have become critical parts of the team. They're the ones coordinating the care for these patients, whether they're in the hospital, but for this class, we need to focus on a case manager organizing a discharge from the hospital to the home. Because certainly when you go out and make the first visit, on day one post-op or post-discharge, I'm assuming that you want as much care coordinated as possible, right? And then once they transition home, who becomes the case manager and making sure everything is going according to plan? You guys, your home health nurses, right? And then case management in the rural setting is much more challenging. Okay, in the urban setting, lots of resources. In the rural setting, not so much. Okay, fewer resources, transportation issues, geographic distance issues. Okay, so we know that case management can improve the health of high risk, say, diabetes populations, right? So let's say you're the home health nurse, and you've accepted to your caseload a severe diabetic patient who has been in the hospital for a week, trying to get their diabetes under control. So you are now the home health nurse. What kinds of services as a case manager, might you want to coordinate for this client? You're in the home. They've just spent a week in the hospital. What are you going to make sure is in place? Because you're kind of the case manager now. You're the home health nurse.
Their medications.
Medications. Going to make sure they have the finances to be able to get their medications. And if not, you're going to have the resources to help them get their medications, right? What if the hospital didn't send them home with a new glucometer? Equipment, you're going to have to make sure they have all the equipment they need. What about teaching, maybe reviewing the teaching of hypoglycemia, hyperglycemia? Remember, once you visit them in the home setting, it's you. You're responsible for making sure all those resources are available for them to continue on their plan of care at home. Okay. 2030 is mentioned here as well. So please review the 2030 access to care in chapter 15. Looks like there's 5 objectives. So please review that. And here's just a bunch of different roles that the case manager may have: consultant, coordinator, educator, liaison, advocate, lots of different roles. Oops. Okay, let's review this. Levels of prevention related to case management. Use the information exchange process to increase the client's understanding of how to use the healthcare system. Remember, secondary is early identification, early intervention. Assessments, and let's see what it says. Use case findings to identify existing health problems. So you're trying to find at risk. Who is at risk in your caseload? And how can you slow that process down? If they're developing a condition or developing a disease, whatever, you need to be able to screen for the at risk. and try and slow that process down so it doesn't get to tertiary. Example of tertiary, they already have a disease or condition. And so maybe you're monitoring the use of their medications. Let's say they start on new medications, monitoring for side effects, right? Okay. I want to skip to the next chapter, which is disaster management. I want to cover that. Where is that in here? Right here. Okay, why do you think disaster management is so critical to be a part of, involved with in the community setting? Okay. Okay, we have two types of disasters. We have natural and human-made. This is in your this is in your study guide. Okay, so we have to understand there's two types, and you have to be able to identify a specific scenario given. Let's say there was an earthquake somewhere, or there was a flood somewhere, or there was a fire somewhere. Was it natural? Was it human-made? Okay, first and foremost. Okay. Number of disasters worldwide continues to increase, as is and the number of lives lost has decreased. Why do you think that is? Preparation, education, and preparation. Okay, there's 4 stages of disaster management. Just need you to know what the stages are. Preparedness, response, recovery, and mitigation. Okay, as nurses in the community, we are expected to be able to participate in any of those 4 stages. Okay, we are essential in every one of those stages. Okay, we can be liaisons, we can make referrals, we can actually provide care, we can do triage, we can do rapid needs assessment. We're expected to function in any one of those. Okay, Healthy People 2030 comes up in this chapter as well, chapter 16. So please know objectives related to disaster mitigation. Do people know how to evacuate? Do people have parents plan for knowing the evacuation plan of the kid's school? And then how do we best prepare for disease outbreak after a disaster? Okay, so mitigation, what is that? Prevention, emergency management. That's the term they use for reducing the risks. Mitigation, try and reduce risks before they occur. Right? Maybe that's building codes or zoning issues or cutting down dead parts of the forest, land development restrictions. Okay, that's all about awareness and education. How are you Red Cross? How to be Red Cross ready. This is what we teach our clients in the community. How do you be Red Cross ready? Okay, so just know that term, Red Cross ready. That's part of what we work with clients in the community. I'm having a hard time scrolling down here. So has anybody ever participated in a disaster drill? You should have them in your workplace. Has anybody participate in a disaster drill? Nobody?
We've had like fire drills. Does that count?
Yeah, well, that's part of it. But has anybody had disaster drills?
Yes.
Yeah.
Yeah. Why do you do, well, second question, has anybody participated in like a citywide disaster drill? Or once or twice a year, they have a simulation, like in Colorado, they do it at the airport. It's
We
a,
coordinate with EMS and like if we have a mass casualty
Yeah.
on the interstate close to the office.
great. What are the purposes of doing mass casualty drills? What's the number one purpose? This is in your study guide.
To get people care. Everybody can't go to the hospital.
Right? Even before that, why do you do the drills?
To be prepared for it.
To make sure you're prepared.
To know
That-
what your role is in the
Exactly.
drill.
Exactly. And for nurses, it's any part of the disaster we can be asked to be involved in. Okay. And the purpose of mass casualty drills is to see the level of preparedness that a community has. They're either going to be super organized, excuse me, super organized and prepared, or they're not, and they need to make some modifications. I actually think it's a federal mandate now that each of the cities has mandatory evacuation drills or mandatory mass casualty drills. Okay, community preparedness, last part of this chapter. So where you work, your community, your own neighborhood, sorry, should have a written disaster plan, and you should be participating in yearly disaster drills. That goes for schools as well, right? Most places have a disaster plan and require employees to participate in annual mock drills. Okay. And then the other thing that is really important with disaster preparedness is having an adequate warning system. Right? I don't know, in our community, we have sirens that warn of an impending tornado. Okay, this is on your study guide as well. So we need to know what agency is responsible for coming into your community and providing some services to your community after a disaster. Okay, it is the National Response Framework. That's actually an agency. Excuse me. And in your study guide, it describes what they do. Okay, so this is one of many federal agencies that respond in a disaster, but for purposes of this exam and this class, we're talking about the National Response Framework. Okay. Okay, so that's what I need you to know about disasters. Okay, the next chapter, managing quality and safety. We're going to go through this pretty quick. You know, you in your workplaces, you have quality management, quality improvement, quality assurance. Well, we also have that in the community. All right, we obviously have to maintain quality and safety in the community as well. Okay, so how do we go about and do this? Whoops. First of all, what's the difference between quality assurance? What's the difference between quality assurance and quality assessment? No, I'm sorry. What's the difference between quality improvement and quality assurance? Quality improvement is we are always trying to take steps to improve whatever, the care we're giving, the research we're using, whether that is evidence-based practice, we're always trying to improve the quality. Maybe we're sending out surveys to patients when they're discharged. How was it? What could we have done better? Okay, that's quality improvement. You're always trying to improve. Where quality assessment is more of what happens if there's an issue. Let's say a patient unexpectedly dies in the OR, or several patients on your stroke floor have recently fallen, or there's an unexpected event. That's where your quality assurance people will get involved. What happened? How did it happen? And what steps do we put in place for it to not happen again? So you're trying to assure quality. All right, where quality improvement is, you're always trying to improve. Does that make sense? That's an important distinction. You can think of quality improvement as always trying to improve your quality. Quality assessment, you're assessing issues that have happened and going through the nursing process and coming up with a plan to improve. Okay, here they are right here. Improvement, mandate to improve the quality and efficiency of services. Okay. How do we improve quality in the community? Assessments, I always doing community assessments, identifying high-risk people, high-risk clients, targeting, coming up with interventions, managing illnesses across the continuum of care. Okay. Surveillance. Why is surveillance and outbreak? We're on a new chapter now. Surveillance and outbreak. Why is this so important in public health? Let's think about COVID. What is the role of the public health nurse in surveillance and outbreak? I can tell you from my experience in the schools, I was always doing surveillance and outbreak. We had cases of pertussis, cases of lice, cases of bed bugs, cases of hand, foot, mouth, cases of chickenpox, strep. And as a school nurse, you had to monitor that. So why is it important in the public health setting for nurses to be involved in that? Well, as public health nurses, we're always, pardon me, we're always collecting we're going through the nursing process. We're collecting information, right? We're making our assessments. Let's say you have an outbreak of pertussis in your schools. What do you need to do?
Report it.
Absolutely report it. And then the health department should guide you onto what to do with the different students. What kind of letter communication you need to send to parents, who needs to stay home. What about the kids that aren't immunized against pertussis? Are they at greater risk? Absolutely. So you need to contact those families. As nurses, well, at least in the schools, I felt like I was always surveilling, always reporting outbreaks, surveilling, educating about what was going on, especially in the preschools. Okay, so what does surveillance mean? Organized and planned, the population's health status. Think of my example in the schools with pertussis. We're assessing the health status of the school, ongoing collecting data. Are other kids being diagnosed? Are other kids exhibiting symptoms? Communicating, sharing results with others. That's communicating with parents. Communicating with the public health department. Obviously, my job in surveillance and mitigation is to try and reduce morbidity and mortality. So you may not realize that, but in community health, you're always surveilling. Okay, so the two things we need to understand here is a passive surveillance system and an active. Okay, so as a school nurse, I was passively reporting. All right, so if I had a case of pertussis, I was reporting that to the local health department. Okay, where then the active system, so passive, I'm doing it from the school to the health department, and then the health department picks up the active system, where they then become the investigators. So let's say I reported 10 kids were in the clinic with GI symptoms. They all seem to be reporting they were at a, I'm sorry, gosh, restaurant last night, and they all ate the same chicken tenders, right? So I report that to the health department. So then the health department picks that up. So now they're in search of additional cases of other people that might have been in the restaurant. So they're now actively surveilling. So those are the two I want you to understand, the passive and the active. Okay, and then let's cover quickly chapter 28. This is what is our responsibility as nurses at the local, state, and national levels. Okay, so we know that there's a federal level of oversight for public health. Okay, the federal oversight, they do provide public health services. They're constantly monitoring our nation's health. Think of COVID here. Okay, they set practice and they set standards, right? They provide the states with evidence-based practice. So what's going on in other countries, what's going on in other states, and they at a federal level can coordinate public health activities across state lines. And they also do research. At the state, right? The state level, so think of your state public health department. They're in charge of reporting or enforcing laws to improve the public's health. They distribute the federal and state funds to local public health agencies. So we have federal, state, and local. Because different communities may need different resources. Different communities may have a higher population of suicide, higher population of chronic disease, higher population of what else? Higher population of older clients. All right, so at the state level, or excuse me, at the local level, they receive the funds from the state, who receive the funds from federal government to do certain programs in the community, right? Maybe it's maternal child health programs, chronic disease prevention, injury prevention. Okay. And then at the local level, right, we're looking at the goal at the local level is to improve your local community's public health, right? Improve their health status. But you're always working with the state, and then the state is responsible for working with the feds. Okay. And that is all. Oh, some history and trends of public health. Increased life expectancy. Why are people living so much longer now? And why is that a trend in public health? What does that translate to? What does that translate into with regards to a community nurse or a public health nurse? People are living longer, so what does that mean to us? Chronic disease management. People are living longer and many more chronic diseases. Okay, and then the last slide I want to cover the issues and trends in public health. Okay, we know that we have increasing rates of drug resistance to community-acquired pathogens such as tuberculosis. We know that we have lots of social issues such as welfare reform. We know that we continue to have racial and ethnic disparities in health outcomes. All right, chronic diseases, increase in violence, substance abuse, mental health issues, and financial issues for families, unequal access to health care. Okay, case managers are becoming much more popular in the community setting, not even so much for discharge for the patient from the hospital to home, but actual case managers being used in the community. Okay, to manage community health resources. Okay. So that's a lot to cover, but we got through it. Does anybody have any questions? I know that's a lot. I want to show you the study guide. Okay, in my just a real quick summary. There's a bunch of different sections in the study guide. Oh, I'm not sharing my screen. Sorry. Hang on. And this isn't a substitute for watching my recording. I just want to give you a brief overview of the study guide. So this is the study guide. I started highlighting this morning in my review, but each bullet represents a different information. This is your concept. Okay, this is your concept, community assessment evaluations. All these headers are your concepts. Okay. Each of the bullets below that concept is information that is helpful to understanding the concept. So for example, when you look at community assessment and evaluation, with each bullet, I would like for you to pull out two things. What information are we providing you so that you have a better understanding of community assessment and evaluation? And once you read that, what information have we given you? So then try and think about what kind of question might be asked. If there is a question about, community refers to the dimensions of place, people, and function. If there's a question about that, what is it going to ask? Maybe what three dimensions are looked at when you're doing a community assessment? What's the answer? Place, person, function, right? You guys with me on this? Okay. What if you're given a scenario and it says, in looking at the dimension of place, where might you get your information for your assessment? Well, it says right here, would be measured with data sources of maps, newspapers, and local housing office. Where would you get your information for if you were looking at the dimension of people? Data sources from the census data, tourist bureaus, civic groups, churches. You with me? So that's what I need you to do. Okay, this next bullet is about community assessment and talks about how do you assess the community? What are some categories you use to assess the community? Well, here they are: politics, education, recreation, economics, religion. Okay, so try and get an understanding of what the bullet is asking. That's why I started highlighting these in my review. So if you want to go back and look at my review, I go into this in much more detail. What information are you being given to support understanding, having a good understanding of the concept of community assessment evaluation and evaluation? Here's the information that we feel is critical for you to have to understand that concept. Okay. And I go through that in much more detail in my review, but that's how I would encourage you to look at the study guide. Okay. Start with the topics, the big picture concepts, start with the big picture concepts, and then review the bullets under each concept. And if you have a good understanding of those bullets, you should have a really good understanding of the concept. And if you don't, mark it up and let me know over the weekend that you want some help with some concepts or information on the study guide that you don't understand, and I'll go over it with you Monday or Tuesday. Okay. And all the information we covered today is on the study guide, week 8. So actually today is, like I said, is it for content. Next week is exam, the following week is Hesi. So you should, the study guide should be familiar to you because we've now covered all the information. Questions? Nobody has any questions? Well, I'll stay on if anybody has any questions. I hope everybody has a wonderful Thanksgiving. Reach out if you need anything between now and your exam next week. Really hone in on that study guide. Okay, if you have a good understanding of the study guide, you're gonna do wonderful on the exam. Okay, don't overdo it.
We're not gonna get the PowerPoint, right?
No.
No, okay.
You have 2 recordings, Jean. You have this
No,
recording.
Making
You have
sure.
this record. You'll have this recording of this class, and you have what I think was a really good exam review from this morning. And I think it was only, when I posted, I think it's only like 54 minutes. Okay. All right, my friends. Have a wonderful Thanksgiving.
You too.
Carve out some time for you tomorrow. And we'll see you next week.
Thank you.
You're welcome. Thanks, Savannah.